As people are still logging in, I'm going to get started and introduce the session here. My name is Brett Sperry. I'm a cardiologist at St. Luke's Mid-America Heart Institute here in Kansas City. And I wanted to welcome you to the first virtual amyloidosis symposium. I have with me my colleagues at St. Luke's, Dr. Ibrahim Saeed from cardiology, and Dr. Shahzad Raza and Furha Kosor from hematology at the St. Luke's Cancer Institute. So before we get started, I wanted to give you a little background on this symposium and some guidelines for how these sessions are going to run this week. We had been planning a local amyloidosis symposium here in Kansas City that was supposed to take place around now, but unfortunately nature had another idea, and so due to the coronavirus we had to decide on an alternative. So we put together this program that will span this entire week, covering several topics in amyloidosis. We have almost 500 people registered from 26 countries, which is a much broader audience than we would have had in Kansas City. So thank you all for registering and for logging in today. And these videos will be available afterwards for viewing as well on the same website. You can see the schedule for the day that is up here now. We're going to cover mostly AL and ATTR amyloidosis during this week. And we would like to start this introductory session by thanking all the fantastic amyloidosis experts who have agreed to participate. Some guidelines about how these sessions will work via Zoom. So we'll try to start on time every day. You can log into the meeting beforehand. It should be open about half an hour before the start of the session. We will have our speakers try to stick to their allotted time slots, and the speakers may ask questions to the audience, and so you can type your answers or thoughts into the chat box that you can see on Zoom. I'm just going to mute all the participants. Thanks. So feel free to ask questions through the chat box. If the speaker finishes before the next talk is scheduled to start, we'll pick some questions from the chat box to discuss. And if not, we have built-in time at the end for questions and for case-based discussion. And so with that, I'll let Dr. Falk share his screen. So I want to introduce our first speaker. Dr. Rodney Falk is an associate professor of medicine at Harvard Medical School and is a cardiologist and director of the cardiac amyloidosis program at the Brigham and Women's Hospital in Boston. I've had the pleasure to encounter a few patients that have flown to Boston to see Dr. Falk in consultation, and they have not been disappointed in his knowledge, bedside manner, and recommendations regarding their amyloidosis. Dr. Falk is a master clinician and teacher to so many residents and fellows who train at the Brigham, and we are honored to have him kick off this symposium with an overview lecture on amyloidosis. Dr. Falk, thank you.
Well, thank you very much, Brett, for that very kind introduction. Overview is a little difficult. I always like to start my talks with a little teaser. So here's three things on here. You have Popeye on the lower left, you have an elderly gentleman in the middle, and for those of you who are Doctor Who fans, you have the TARDIS, which is the police box, which over the last 50 years has been transporting Doctor Who throughout time and place. And my plan is to at least transport you a little bit throughout time in the 45 minutes of time that was allotted to me for this task. And I'm very grateful and honored to be kicking off this symposium. So I thank you very much. See if I can change the slides. Okay. My disclosures. And I'm going to concentrate on the heart as I'm a cardiologist, but I'm also cognizant throughout all of this that we're talking about amyloidosis in general. And as Brett has pointed out, AL amyloidosis and TTR amyloidosis are the major types that we're going to be talking about today, predominantly because they are the commonest. Let's start in the past, since my task is to give an overview of amyloidosis. Before doing so, though, let me ask the question as, does the past really matter if we're dealing with a topic that is rapidly changing? And I would argue that it does. Two well-known figures, not in the world of amyloidosis, but to be quoted. In The Tempest, Shakespeare writes, "What's past is prologue." And Confucius, many generations before, tells us to study the past if you would define the future. And at the end of this lecture, I'm going to look a little bit towards the future. I can't say I'm going to look into the future to see if what might be occurring in the next decade or so in this disease. So the gentleman on the first slide was Rudolf Virchow, who was the person who first coined the term amyloid back in 1854, for the reason that he thought that this was related to cellulose, and this is a term in botany. And Virchow actually features again, at least in cardiac amyloid, although little recognized, but I'll show you that as the lecture proceeds. Congo red, which is part of the title that I was given. Here is a very brief history of Congo red. It was synthesized as a dye back in 1883, and initially was not wanted by the company that for whom the chemist was working, but eventually became a huge commercial success. And in 1922, so well after Virchow described amyloid, it was found to stain amyloid, and the apple green birefringence seen here on the left of the slide, which is so well recognized, was discovered by Jeffery. Very interesting article here that you can see on the web, which I would recommend. It's a brief article about the history of Congo red. Now, if we're looking into the history of amyloidosis and getting into the 20th century, here is a quote from way back in 1966, originally in German, which translated, you can see that basically the pathologist at that time suggested that it is a strange disease, a sphinx-like disease that has puzzled or did puzzle pathologists for generations. 34 years ago, which was at a time that I was already in the field of amyloidosis, this quote from Cancer and the Heart is very striking. It shows you how far we've come. There's no specific treatment for primary cardiac amyloid, which is what AL used to be called, for secondary amyloid involving the heart, or for heredofamilial amyloidosis. So not only is this something that is striking for us today, but what I want to point out to you is the fact that there is no mention here of what initially was called senile cardiac amyloidosis and subsequently wild-type transthyretin cardiac amyloidosis, a disease which has become one of the commonest forms, if not the commonest form, of this disease. Even as late as 1987, we were really stuck in the past. It was known that colchicine was useful in patients with familial Mediterranean fever for preventing the onset of secondary amyloid, and people were still using it as the only treatment for AL or any form of amyloid at the time. And this was published back in '87 from the BU group using an historical control, suggesting maybe a marginal benefit of colchicine, although as we well know, it really is totally ineffective in this disease. So when did the modern era of treatment begin? It began in the late 80s and early 90s with the use of melphalan for the treatment of light chain amyloidosis. This wasn't published until 1996, and even then it was thought that perhaps colchicine was useful. So you can see this trial of melphalan, prednisone, and colchicine versus colchicine alone, published back in 1996, and you can see a marginal benefit. MPC is melphalan, prednisone, and colchicine, a marginal benefit in AL amyloidosis, but still with a median survival of less than 2 years for all comers. And most strikingly, if you look at the table on the right, you will see that cardiac amyloidosis here had a median survival of 4.4 months, with 5 months in the colchicine group, 4 months in the MPC group, not statistically significant. So it didn't work. Melphalan and prednisone didn't work. The main reason being it took so long for it to begin to kick in that most of the cardiac patients were dead at the time. And that has been a problem throughout and still remains somewhat of a problem today. I would say that the beginning of the present era for the treatment of light chain amyloidosis started with the publication of this paper in 1996. Ray Comenzo, who was then at BU, along with most of us, pioneered dose-intensive melphalan with blood stem cell support for treating amyloid. And our first 5 patients shown here were changes, oddly, an odd thing to use in the neuropathic disturbance at baseline and 1 year. But it was the first paper that really showed that if you treated someone and obtained a hematologic remission, and in those days that was difficult to determine, as we did not have free light chain measurements, that the disease began to regress. Let me step aside a moment from TTR amyloidosis, from AL amyloidosis, and look at some timelines of TTR amyloid. Familial amyloid polyneuropathy has been recognized since Andrade described it in the early 50s. And in those days, cardiac manifestation was thought initially to be due to conduction system disease. It was not until 1978 that TTR was recognized as the precursor protein of familial amyloid polyneuropathy. Remember, wild-type TTR had not really been described at the time. And it was perhaps recognized as senile systemic amyloid, but only from autopsies, and it was considered a very rare form of amyloidosis. Subsequently, people recognized that as TTR was almost exclusively expressed in the liver, maybe liver transplantation worked. And as we all know, it did work. It was introduced in 1990 for the therapy of familial amyloid polyneuropathy, but of course cannot be used for wild-type TTR because what you're trying to do is replace the abnormal protein, the mutant protein, produced by the liver and put a new liver in, which is producing wild-type TTR. I would say somewhere in the late 90s, we moved from what clearly was the past when we barely understood the different forms of amyloid into the beginning of the present. And let me talk a little bit about predominantly discoveries, but also on the way, some disappointments. Before I do so, I would say that there were 3 things that have helped us enormously in the transition between the past and the present. The first was a recognition. It wasn't anything other than that. It was a recognition brought to notice in the New England Journal by Helen Lackman for the London group, that at least even there, the best center, one of the best centers in Europe, 10% of patients who had been sent to them or diagnosed as light chain amyloidosis actually did not have that and had non-AL amyloidosis. So that there was a misdiagnosis. It was around about that time in the late 1990s, early 2000s, that serum-free light chains were introduced and made it a lot easier to determine whether a patient had AL amyloidosis or not. It made it easier, but didn't definitively define that. And it was really only with the availability of laser dissection mass spectrometry, pioneered at the Mayo Clinic, that we realized that not only were some patients misdiagnosed as AL amyloidosis, but there were a whole new group of rarer amyloid out there, and that there had been many patients, or a significant proportion of patients who had undergone high-dose chemotherapy for so-called AL amyloidosis, who in retrospect never had it because monoclonal gammopathy coexisting with other diseases such as TTR amyloid was quite prevalent, and in fact up to 20% or more of patients with wild-type TTR. One of the great problems that still is a major problem is the fact that if you have cardiac amyloid, that's what increases your mortality, and untreated, that's what's going to kill you. And if the diagnosis is delayed, the question is there a point at which it's not even worth treating a patient? In other words, when is too sick too late for treatment? Here's an echocardiogram showing severe advanced amyloid with a large pericardial effusion. The concept when stem cell transplant came in, which was the first time that we could really switch the disease off, was that if you got rid of the plasma cell dyscrasia, you stopped the progression of the disease because you were not depositing any further amyloid, and that was all there was to it. It was well recognized that, looking at graph B here, that cardiac involvement, the lower graph, had a much worse prognosis overall. This is data from Pavia than non-cardiac involvement, and that if you were a responder to whatever therapy you were given, that you did a lot better than non-responders, because it was thought that non-responders just continued depositing amyloid, and that of the responders and non-responders, the cardiac patients did worse, but they did particularly bad if they were non-responders. A seminal paper came out in 2007, which I think is really important to look at. It caused a lot of controversy because it seemed to show, in fact, it did show, that melphalan and dexamethasone, given orally, were no better, in fact, were marginally, was no worse, in fact, were marginally better than high-dose melphalan and stem cell rescue. This was after everyone was saying that high-dose chemotherapy with stem cell transplant was the gold standard. The major criticism of this paper was the high mortality seen in the red line here in patients who underwent stem cell transplant. This was a multi-center French study in which some of the centers were not particularly skilled in treating amyloidosis. And it was felt that the lack of experience was associated with a higher mortality. That indeed may have been the case, but I would argue that regardless, and if you look at data from any center, even the very best, who are undergoing stem cell transplant, that there is a very high early mortality, which then, if you go into remission, if you get through it and go into remission, you do quite well. And that regardless of the center doing it, if you have cardiac disease, you run the risk of falling into that mortality group. And so there became an increasing selection of patients, less and less of whom had high-dose chemotherapy if they had cardiac involvement. But there was more to it than just switching off the disease and then hence switching off progression and hence slowing or stopping mortality. And I want to show you a patient that I think, at least in my mind, made an enormous difference, a single patient, in the way in which we think about what's happening in AL amyloidosis when you switch off the plasma cell dyscrasia. This is a younger me by 25 years and a shorter patient than he was when we originally met him. Why do I say shorter? The story goes that Simon Dubray, who was then working with me, he's now in London, who was then working with me in Boston, set out to look at over 200 patients with cardiac amyloidosis and what was their natural history. These were patients seen at Boston University. This gentleman here had been seen 7 or 8 years before. When we saw him, he had had a cardiac arrest during a cardiac catheterization. He was in class 4 heart failure, and he was wheelchair bound. Simon put together and documented a complete series on every patient except this guy and told me I can't find any more data on him. We looked at his chart, and we had talked about very openly with him the fact that he would be dead in a couple of months. It turned out that he was still alive in a couple of months because he had written to us 3 or 4 years later. This is 5 years after he was treated with just oral melphalan and prednisone. We brought him back. He was no longer in heart failure. We examined him. We looked at his neck. His neck veins were up. His echo looked the same. We found no evidence of a plasma cell dyscrasia. We went back and looked at a group of 120 or 130 patients treated with melphalan and prednisone. That's all we had at the time. And we found 3 in whom the plasma cell dyscrasia seemed to have totally disappeared and who had done very well, despite the fact that their heart looked exactly the same. And we postulated at that time that the abolition of light chains seen in these 3 patients suggests they were so sick before and they got better. This particular guy got particularly better, that the light chain toxicity may play a role in the genesis of heart failure in patients with AL amyloidosis. That was taken to the lab with Rongli Liao and the late Carl Epstein, who showed for the first time in 2004 in a lab model that light chains from patients with cardiac amyloidosis had a marked negative inotropic effect on cardiac myocytes. And that was not seen with a vehicle or control light chains from patients with multiple myeloma who did not have cardiac involvement. Subsequently, the work continued over the next decade and was elucidated so that a whole flow of, in the lab, cardiomyocytes exposed to amyloidogenic light chains showing this progression of lysosomal dysfunction, dysregulated autophagy, all the way through to cell death. And this is work that Rongli Liao, now in Stanford, has been working on since 2004. So there is no doubt that light chains themselves are toxic and they play a role. It is not just that you've switched off the light chains and hence no more progression. It is you are getting rid of the toxicity, and there may be, and indeed has shown to be, improvement in these patients following abolition of their plasma cell dyscrasia. Now, I think that an important point came along in the management of AL amyloidosis with the Mayo Clinic staging system. Each risk factor gets 1 point from 0 to 3. So stage 4 has all of these adverse risk factors shown on the bottom right, 2 of which are cardiac and 1 of which relates to free light chain difference. But there is a problem here. And the problem is that this was published in 2012. And if you look at the patients who were in this, the majority of them did not get modern therapies. They received melphalan-based therapy, many with stem cell therapy, but they did not receive bortezomib, and certainly they did not receive daratumumab. And going back to this early mortality, since many of these patients were getting very intensive therapies, it is feasible that those therapies were increasing the mortality. With bortezomib, which is rapid onset, and certainly with daratumumab, what we now have, which is very rapid onset, it is potentially possible and actually practically possible to modify that early mortality and see a better survival. These are data we put together probably 18 months or 2 years ago now from a relatively small group, about 50, our first 50 patients at the Brigham with bortezomib-based therapy. With the Mayo score, this is the median survival on the left, or the middle column rather. And I want to draw your attention to the sickest patients, which were Mayo stage 3, which had in the original staging system a 14-month median survival, not reached with bortezomib, and 5.8 months survival with Mayo stage 4, which most of our patients were in Mayo stage 4, 40-month median survival. So this is due to the new therapies. And if you applied the older therapies, if you applied the older staging system, you would give a very bad prognosis to patients. They have a bad prognosis, but there is hope for many of these people. Let's jump now to one of the disappointments of liver transplantation. In Simon Dubray, who I mentioned earlier, also showed a very interesting thing in liver transplanted patients seen at Boston University who had, at the time of liver transplantation, some evidence of cardiac involvement. He noted that after transplantation, this is wall thickness of the left ventricle, continued to get thicker. Those who had normal wall thickness did not. And it appeared that there was therefore progression of amyloid. In that paper, we postulated, and it was later confirmed by a Japanese group, that the only way that the heart could be getting worse, if you've taken out the mutant TTR, and you assume that it's getting worse because there's more TTR being deposited, is that there must be deposition of wild type TTR, that what is in there acts as a catalyst to further deposition. And this has been shown to be the case. So liver transplantation is reasonable, but once you have cardiac involvement, even if you can get through the procedure, it may progress. And therefore it is not the be all and end all, even if it were a simple procedure, which it is not. Well, as everybody here who's listening knows, I'm sure patisiran and inotersen really have revolutionized the therapy of mutant TTR. They can lower not only the mutant protein, which is what liver transplant does, but also wild type protein. And these are the figures from the New England Journal paper a couple of years ago, showing that both patisiran and inotersen have a dramatic response in slowing familial amyloid polyneuropathy in the trials compared to placebo. That's good news because the commonest form of TTR amyloid is not the mutant form, but it is the wild type form. And I would say that every center that has looked, that has been in business, as it were, for more than a decade has seen data like this, which has come out of the London group. If you look at the gray curve that suddenly exponentially takes off, these are the number of cases seen each year at the National Amyloidosis Center with mutant TTR, that's in the orange and blue, the blue being non-isoleucine 122 and the orange, the isoleucine 122, about 20 cases a year since 2008, with a massive increase from virtually no cases a year prior to 2008 to 150 cases a year in 2014, and probably hundreds more per year since then. We've all seen this, that the disease of the day for amyloidosis is not AL and it's not mutant TTR, it's wild type TTR. The ATTRACT trial, which was the effects of Tafamidis on patients with amyloid TTR cardiomyopathy, predominantly but not exclusively wild type TTR, really revolutionized the treatment of this disease. and showed that Tafamidis slowed but did not stop the disease and decreased by decreasing mortality and decreasing cardiovascular hospitalizations. And on the basis of that, Tafamidis, which Jeff Kelly is going to speak about in great detail after my talk, Tafamidis has played a significant role now in the treatment of TTR amyloidosis, despite its considerable cost to a significant proportion of patients. I'm not going to say much more about this at the moment because Jeff, I'm sure, will give us all the details of it, as he is really the person who invented or discovered or put together Tafamidis and has been a major player in the field of TTR amyloid. There are other trials though. So Tafamidis is a stabilizer of TTR. These are the other trials that are starting or just starting or ongoing. The first one, ATTRibute-CM, is another stabilizer, AG10, 500 subjects with a 12-month endpoint of a 6-minute walk. This is for TTR cardiomyopathy, a 30-month endpoint of all-cause mortality. And the remaining 3, one of which looks at patisiran in patients with amyloid cardiomyopathy, and the other 2 look at son of patisiran, vutrisiran, and son of inotersen, Axia TTR LRX, given respectively as quarterly injections and monthly injections to lower the levels of TTR in order to see whether we have a benefit of these drugs and whether they're better than a stabilizer, at least the last 3, the top one being a stabilizer. Let me say a little bit briefly about antibody therapy. Antibody therapy, this was an astonishing paper in 2015, Professor Pepe's group from London, in which dual antibody therapy targeted against serum amyloid P, which is found in all types of amyloid. Initially a drug to lower SAP levels in the blood, to weigh down, following which you give the antibody, and that attacks the SAP around the fibrils, and taking off the coating, as it were, the drug can now be attacked by the antibodies and the amyloid, at least in the series that was published in hepatic amyloid, dramatically disappeared. So we know that this works. But hepatic amyloid is much rarer than cardiac amyloid, and the drug was put into a trial of cardiac amyloidosis, a phase 2 trial, which about 2 years ago now was discontinued by GSK after just a few patients were in it because of a severe episode of vasculitis in a single patient. I think this is very unfortunate. There were not enough patients in here to determine the risk-benefit ratio, but it was an extremely complex protocol. But it does show that amyloid can be broken down by antibody therapy. A less effective drug, or perhaps a less effective trial, was the NEO-DO01 trial, the Prothena trial, which was a randomized trial of patients with persistent cardiac dysfunction. And at the end of the day in this trial, the primary endpoint being the best cardiac response, it was deemed a failed trial. I would argue that this is possibly not a failure of the drug, but a failure of trial design, because the endpoint was a single drop of NT-proBNP, a marker, cardiac biomarker, by 30%. And it said, I don't want to be negative towards hematologists, absolutely not, but this was a cardiac trial designed by hematologists who perhaps didn't recognize that NT-proBNP fluctuates a lot, and that to see a 30% drop is not uncommon. And if it just occurs once, that does not mean you've had an improvement. You need a sustained drop. So by using a single point it was doomed to failure from its design. We still don't know whether this works or not, or would have worked if 2 consecutive drops in NT-proBNP were taken as an endpoint. There are antibodies in the pipeline. Calum has Calum 101 for AL amyloidosis. There's a dose-finding phase 1 study in progress. Prothena has bounced back, now also with a phase 1 study targeting TTR. And there is a paper in the European Heart Journal earlier this year of an IgG monoclonal antibody targeting aggregated TTR that in the preclinical stage shows some very promising data. Well, we talked about a variety of things. You can't treat amyloidosis if you can't diagnose it. Let me briefly run through modern techniques because they're very important. Speckle imaging, strain imaging, for those who are not cardiologists, looks at the contraction of the heart along its long axis. This is normal imaging, and this is amyloid, where you have this so-called bullseye pattern, where the amyloid, or rather the function of the heart, is preserved towards the apex and is abnormal at the base. Technetium DPD and PYP imaging have been used since the early 1980s, but it was only in the last decade that Professor Rapezzi in Bologna recognized that this uptake of a bone imaging isotope occurred in TTR amyloid and very less intensely in AL amyloid. And it's become now a diagnostic test for TTR, DPD in Europe, and in the United States, technetium pyrophosphate. Cardiac MRI that Mariana Fontana is going to talk about on the last day, I believe, is also revolutionized the diagnosis, but cannot distinguish between AL and TTR, whereas pyrophosphate DPD scanning is good at distinguishing between the two. And florbetapir, which is needs PET CT scanning to do properly. We're doing a lot of work with this. My colleague Shamila Dobala is taken up very avidly in not just the heart, but in the lungs and different organs of the body in patients with amyloidosis. Here is cardiac amyloid, that's bright. The bright colors that you see in the top and the bottom panels is amyloid in the heart. And here is an example of a patient who presented with a bullous hemorrhagic rash, had been followed for 3 or 4 years. No one could figure it out. Somebody thought of amyloid, had markedly elevated free light chains, no evidence clinically, echocardiographically of amyloid in the heart, but the florbetapir does show uptake. So although it was apparently just in the skin, with florbetapir we can see it's beginning to occur in the heart, even though the MRI on the left and the echo not shown did not show any typical amyloid, nor were the biomarkers up. If you're thinking of the heart, don't forget the atrium. Here we go with Virchow's. Virchow's triad talks about thromboembolism occurs with stasis, with abnormality of the vessel wall, in this case with the atrium, which is infiltrated with amyloid and is all roughened, and abnormalities of clotting, which may occur, particularly if you have nephrotic syndrome in AL. Here's a patient in sinus rhythm. This is on the left, flow across the mitral valve, which should have an E wave and an A wave when the atrium contracts. There's no A wave because this atrium is dead because of amyloid infiltration. This patient had flank pain, and you can see he's taken a bite out of his kidney from thromboembolism. Despite sinus rhythm, he and many others have a very high risk of thromboembolism in this disease. Let me go back even one stage simpler and say you can't confirm it if you don't think of it. You can think of amyloid on a desert island. This patient says, I don't feel so well. He's eating a lot of sodium. His friend who's trained in medicine says, let me take a look at your neck. He asks him to take a slow, deep breath in, and the veins go up. This is Kussmaul's sign. Kussmaul's sign only occurs in constrictive pericarditis and restrictive cardiomyopathy. He asks him, any other things happen to you? He says, yeah, I've had this bruising around the eyelid. He says, not only do I now know you've got amyloidosis, but the overwhelming likelihood is you have AL amyloidosis. Let me throw out one other hint, and that is patients with ALIS 60 can also get periorbital bruising. And of course, he may have had carpal tunnel syndrome. I showed you Popeye on the initial slide. Why Popeye? Well, the Popeye sign is what's seen in ruptured biceps. We know that amyloid, TTR amyloid particularly, gives you spinal stenosis, carpal tunnel syndrome. And we did a series of 100 or so patients with TTR amyloid, found a prevalence of 33% of ruptured biceps, very simple to do, compared with 8 per 100,000 in the general population. If you present, particularly a man, since TTR wild type is a disease of men, and you're over 70, you've got heart failure with preserved ejection fraction, there's a 66% chance if you have a ruptured biceps tendon that you've got amyloid. That's pretty good, particularly in the era of COVID, where we're Zooming and you can actually look at this on Zoom if you have a new patient. Well, let's gaze into the crystal ball, and I'm going to ask what the future might bring. And I'm going to use as an example of what it might bring, Christina Cuadra's survey on patients with mutant TTR amyloid due to the isoleucine 122 from the ARIC study. This was published in the New England Journal 5 years ago. And to our surprise, there was no difference between carriers and non-carriers in the mortality. But if you look at, freedom from heart failure, there's an increase, 50% increase risk in heart failure, despite an absence of significant numbers when we looked at the echocardiograms, or Christina looked at the echocardiograms, of typical amyloid echo. And we postulated in this paper that the increased heart failure, despite the fact that the echo did not look like amyloid, may be due to the fact that these patients, by virtue of having the amyloidogenic mutation, had some degree of amyloid, not enough to cause an abnormal echo, superimposed on a second disease, whether it's hypertension or diabetes that makes the heart stiff, and that was enough to push you into heart failure. In other words, a little bit of amyloid with a little bit of something else may result in diastolic heart failure. That's with the isoleucine 22 group. But maybe the typical echo of TTR, wild type TTR, is the only one manifestation of the disease. And as the population ages, diastolic heart failure increases. We attribute this to hypertension, coronary disease, and age-related fibrosis or combination. But maybe if you add a little bit of amyloid in there, you can tip a person with one or more of these other features into heart failure. And it may be that TTR amyloid, without a typical echo, is responsible for heart failure, diastolic heart failure, in a significant proportion of patients. Finally, let me just finish up by another aspect and go back to the ATTRACT trial and ask whether sicker patients respond less well to tafamidis than less sick. And if you look at the table from that paper, class 1 or 2 heart failure here have a statistically significant survival, whereas class 3 patients, there was not a benefit of tafamidis on survival. And there was actually an increased risk of hospitalizations, much less hospitalizations in class 1 or 2. So you have to ask yourself the reason, why might that be? It might be that there's inadequate TTR stabilization. That's what the AG10 people are hoping is the case because they have a more potent stabilizer. It could be, though, that there is a point of no return, at which point, no matter what you do, the patient won't get any better because they've got so much amyloid in the heart. Or it could be a combination of both. There are those who have argued that the silencer trials that I showed you before, since the silencers seem to be a whole lot better in amyloid polyneuropathy than tafamidis is in that they should be a whole lot better in amyloid cardiomyopathy. But I'm going to argue that might not be the case. Just ask, why is the heart thick in cardiac amyloidosis? Because, as shown here with sulfated Alcian blue, there's as much amyloid in many of these hearts as there is myocytes. Maybe 50 or 60% of the heart is amyloid, by the time you develop heart failure. That is not the case in amyloid neuropathy. Here is a sural nerve biopsy from someone with significant amyloid polyneuropathy, and it's all nerve and a little bit of amyloid. So a small amount of amyloid in the nerves can give you bad symptoms. You can stop things there. But if you switch off amyloid production from whatever means in the heart, you may have reached a point of no return, and it could be that whatever you do, you can't get anything better than we've already seen with a stabilizer. So the prediction that silencers may beat or be additive to stabilizers in TTR amyloid cardiomyopathy may not turn out to be true. Or as Robert Storm Peterson said, prediction is very difficult, especially about the future. So where are we now? In May 2020, we've come an enormously long way from Virchow and an enormously long way from the early 1980s. The state of the art in amyloidosis, we've got a lot of the pieces. We may even have all the pieces of the jigsaw, but you have to put the jigsaw together properly, and we're not quite there yet. Thank you very much.
Fantastic. That was great. I wish we had a applause track here. That was really fantastic. Thank you. That was great, Dr. Falk. Really looking at both AL and ATTR, novel treatments that are on the horizon, diagnosis, really everything was really great. And we'll be going into several of these points in subsequent days on the days that are more focused on AL and ATTR and imaging. We're actually going to have Dr. Wall go next because Dr. Kelly is still working through some Zoom issues with IT. But while Dr. Wall is getting ready, Dr. Falk, I feel like we have time for maybe one question that I had, which is that there's often a significant lag time between when symptoms start, which you alluded to, and then when a diagnosis of amyloidosis is made. And we have healthcare providers here from many different subspecialties. So what piece of advice would you give to the non-amyloid specialists with respect to getting to a diagnosis of amyloidosis quickly to avoid a lot of these delays?
I think there's two things. I think if we look at amyloid neuropathy, which I really didn't touch on, the familial amyloid the neuropathy is really part of familial amyloid polyneuropathy, and much, much, much less so in wild type. Neurologists, in my experience, given a neuropathy of unknown origin, have for 20 years been ticking off multiple boxes, copper and this and that and the other. It only takes one more tick to tick a genetic test. So we have to get through to the neurologists that check off the box that says genetic testing for amyloid. And you'll make a diagnosis maybe years earlier in these patients. I think for amyloid cardiomyopathy, the first thing to recognize is it's a lot commoner than people recognize. And if we got to get that through to cardiologists and general internists and a variety of people, and that's not something that I read about that in medical school, and I can't remember anything about it, so I don't care about it. And if you think about it, since virtually everybody with congestive heart failure gets an echocardiogram, and the echocardiographers think about it, then we're going to see it. And that's one of the reasons why we're seeing this enormous uptick in wild-type TTR, because there is an increased recognition, and also there's an increased use of cardiac MRI, and that has a very, very, very distinct footprint. So it's very simple, as I showed really for the clinical aspects. Clinical history is probably going to get a significant proportion of your patients. You don't ask the questions and you don't think about it, you're not going to make the diagnosis.
Perfect. Thank you so much. Well, it looks like we do have Dr. Kelly logged in, and so I'll go ahead and introduce him. We'll get to him next. He's logged in under Rebecca here. So I'm really excited to introduce Dr. Jeffery Kelly. He's a professor of chemistry and co-chairman of the Department of Molecular Medicine at Scripps Research Institute. For those of you who don't know Dr. Kelly, and Dr. Falk alluded to this previously, his career is truly inspirational. His translational research into protein folding, misfolding, and homeostasis has generated several breakthroughs in multiple types of amyloid diseases. Most notably, his work in ATTR amyloidosis has led to the discovery and development of Tafamidis. So again, I'm honored to introduce Dr. Jeff Kelly.
Oh, it's a true pleasure to be here. I'm sorry, Rodney. I logged on 15 minutes early and it took me an hour to get on, but thanks to Rebecca, I'm here. Let me see, I gotta share my screen, I think. Share. Okay. Hopefully you guys can see my slides.
Yeah, we see it under the presenter view.
Okay.
So we see your notes and everything.
Let me, I didn't mean to hit that. Let me see, play from the start. How about that? Is that better?
Yes, perfect. Thank you.
Excellent. Well, it's a real privilege to be here, at least virtually. My disclosures are that I had the privilege of discovering Tafamidis and I still receive royalties from that drug. So let me get rid of all this stuff here. Just sorry, 1 second, guys. I need to rearrange my screen a little bit here. So when my lab started investigating the etiology of amyloid diseases in 1989, the hypothesis was that amyloid infiltration of the extracellular space of postmitotic tissues was causative, and the concept was that proteins like transthyretin got cut by proteases, and that's what allowed amyloid to form. And while there's no, I think, debate that amyloid infiltration of the heart is bad, I think there are other factors in these diseases that I'll have more to say about today. See. Sorry, guys. One more thing I have to figure. Oh, here we go. Great. So I like to think about the transthyretin amyloid diseases as being cell non-autonomous, or in other words, intrans gain of proteotoxicity diseases. So let me explain. So the liver secretes transthyretin into the circulatory system as a tetramer, and then it has to dissociate, misfold, and aggregate into a spectrum of structures, including amyloid fibrils, one of which is depicted here. And this process of aggregation destroys postmitotic tissues like the heart and the autonomic and peripheral nervous systems, and eventually the central nervous system. Interestingly, none of those tissues actually make transthyretin. So this process of misfolding destroys the tissue from outside in, and hence the cell non-autonomous nature of these disorders. So I think Rodney must have mentioned the tissue tropism of these diseases, because there was a nice question when I joined. And the idea is that, you know, wild type transthyretin aggregation causes a principal cardiomyopathy, whereas there are other mutations that present both as a cardiomyopathy and a polyneuropathy. And then there are additional mutations, and in certain early onset cases, that present as a principal polyneuropathy. We suspect the tissue tropism is aggregate structure based. We have some evidence for that, and maybe we can talk more about that in the question and answer session. That's certainly the case, it appears, for polyneuropathy. But in cardiomyopathy, we've been stymied in that we haven't been able to detect any circulating aggregates in these patients. Of course, that doesn't mean they don't exist. So there's now very strong genetic evidence for the amyloid hypothesis. And I define the amyloid hypothesis as the process of transthyretin aggregation causing these maladies, as opposed to the fixation on one structure of aggregate, which is this cross beta sheet amyloid fibril. There's very strong genetic evidence that I'll cover today. And of course, over the past few years, owing to a lot of efforts by physicians such as Matt Maurer and Teresa Clayho and others, they've generated very strong pharmacologic evidence for the amyloid hypothesis. And I'll have more to say about this later. There are a lot of aggregate structures that are now coming out in the literature, both from X-ray crystallography and from cryo-electron microscopy and the like. And since we really don't know or have a structure-proteotoxicity relationship, we posited from the outset that inhibiting the entire process of aggregation would be the key to clinical success, because you don't have to guess which of these structures are driving the proteotoxicity. The mechanism by which protein aggregation leads to the demise of postmitotic tissue also remains clear. It's not that there aren't any data-based hypotheses. In fact, there are a lot of them, suggesting that inflammation is involved. Clearly, protein trafficking and transport within cardiomyocytes and other cells is quite compromised. There's consumption of proteostasis capacity. There's a lot of aberrant signaling, and it's probably the case that these diseases arise by multiple pathologic mechanisms which individually wouldn't cause the disease, but collectively they do. At least that's the current thinking. So there's several forms of transthyretin that circulate. The transthyretin tetramer shown in blue on the right can transport haloretinol binding protein. It can also transport thyroxine, as is shown on the left. But the form that we think is responsible for aggregation and amyloidogenesis is the structure depicted in the red box, that is the transthyretin tetramer not carrying any ligands, and thus it's relatively destabilized to the other forms of transthyretin that are circulating. When we started our research in the late 80s, even at that time, there was sufficient evidence suggesting that aggregation was really the driver of these pathologies. We spent a lot of time looking at the cell biology of secretory cells like hepatocytes. And the bottom line is that most of the familial mutants get secreted at wild type-like levels. So there's very little in the way of quality control for the vast majority of the TTR sequences that aggregate. Probably the most important contribution to the literature that we made, at least with respect to therapy development, is that the rate-limiting step for transthyretin aggregation or proteolytic events is dissociation of the tetramer, which is actually quite slow. Once the tetramer dissociates to monomer, it typically snaps back into a tetramer, but occasionally it can misfold, and that drives the formation of numerous aggregate morphologies. So the other major kind of contribution I suppose we made in this aggregation regard is to show that conformational changes alone allowed transthyretin aggregation. So what's the deal with all these variants? There are more amino acid substitutions than there are amino acids in transthyretin that lead to amyloidogenesis. The bottom line is that they all destabilize the tetramer, typically making the rate determining step for aggregation, that is tetramer dissociation, faster. Thus, the concentration of the aggregation-prone misfolded monomer builds up, and that puts the patient at higher risk for aggregation and hence degenerative pathologies. When Ted Foss was a graduate student in my lab, he did some really clever experiments that showed that the transthyretin tetramer actually comes apart by way of the bottom pathway here. And this was a really good day for us and especially the patients, in that this is the dimer-dimer interface that creates the two unoccupied small molecule binding sites that carry thyroxine. And as I said, these binding sites are 99% unoccupied in the plasma in humans. because there are two other high affinity carriers of thyroid hormone. So the therapeutic strategy that we envisioned was to create small molecules shown here diagrammatically by these green boxes that bind to these unoccupied binding sites, stabilizing the tetramer in a functional form that can still bind holoretinol binding protein and preventing it from forming all of these aggregate structures, including amyloid fibrils that putatively drive neuropathy and cardiomyopathy. And we rationalized from the outset that this was a conservative approach in that it does not require an understanding of structure proteotoxicity relationships in order for clinical success to be achieved in a clinical trial and subsequent commercial settings. So while we were busy at work making small molecule kinetic stabilizers, we call them kinetic stabilizers simply because they slow down the rate of dissociation. So while we were busy at work making molecules of that sort, a really important observation was made by Teresa Callejo's, depicted in the upper right-hand side of this slide. Basically, she was taking care of a lot of individuals in Portugal who have the BEL30 MET mutation and develop polyneuropathy. And she noticed in a few large families that only half of the carriers develop polyneuropathy and that the other carriers seem to be largely normal. And she was smart enough to sequence these individuals. And it turns out that they have the 3119 MET mutation on one allele and the pathogenic BEL30 MET mutation on the other allele. So therefore, they make heterotetramers comprised of these two mutant subunits. And when Per Hammerstrom was a postdoc in my lab, he figured out through a number of elegant experiments that the way that this interallelic transsuppressor works is that it destabilizes the transition state for tetramer dissociation. So the way to think about this, I suppose, is by a hiking analogy. You remember probably nightmarishly from chemistry, these free energy reaction coordinate diagrams where a starting material to go to product has to go through a high energy transition state. And the way that this interallelic transsuppressor works proportionally to the number of subunits in the tetramers that increases this barrier, therefore it really slows down tetramer dissociation. So hence, tetramer dissociation is required for aggregation. That's basically what this human genetic discovery that Teresa Callejo made and we translated biochemically. You can see that really nicely in this slide. So that basically as you increase the number of these red 3119 MET subunits, the rate of tetramer dissociation or fibril formation, the curves are almost identical, really slow down to the point where it basically doesn't happen. So what Mother Nature does by way of this interallelic transsuppressor is that she increases the transition state associated with tetramer dissociation and thus prevents the pathology because the misfolded monomer can never form, or at least it forms very inefficiently. Now, chemically, we have no idea how to manipulate transition states because we don't have structures of them and we can only kind of look at them computationally. But what we can do is analogously increase the barrier for tetramer dissociation simply by selectively binding ligands to the native tetramer, that is these kinetic stabilizers like Tafamidis. So long as they bind to the native tetramer and not the dissociative transition state, then you get an increase in the activation free energy and thus a slowing in tetramer dissociation proportional to the binding constant of the small molecule. So when Evan Powers was a postdoc in the lab, he sat down at a computer some 12 years ago now, and based on a lot of crystal structures we had of small molecules that we were making, he designed Tafamidis because he thought it would fit really well into the protein and make complementary hydrogen bonding and so on. Now we had a lot of ideas like this. Most of them failed, but Evan's idea succeeded. This turned out to be a really potent small molecule, as you'll see in just a couple of seconds. The KD is 2 nanomolar for binding to the first site and about 100 to 200 nanomolar for binding to the second site. Now, to quantify this concept of kinetic stabilization by pharmacologic agents like Tafamidis, we use this so-called subunit exchange assay. So the easiest way to think about this is that the black tetramer is that found in the patient's plasma, to which we add a red tetramer that has little tags on it that in an ion exchange column make it separate, and proportional to the number of the tagged subunits that are in the tetramer. So if there's no subunit exchange, you'll only see peaks 1 and 5. But if the tetramers can exchange, then you see all of the peaks corresponding to the statistical distribution of tetramers here. Now, you could never see this in plasma because there's thousands of proteins there. So the trick to making this work was we conceived of a small molecule that's dark in solution and dark even when it binds to transthyretin, but when it reacts, forms this amide bond, it makes the tetramers fluorescent. And so now you can see these tetramers. And additionally, what's nice about this small molecule is that it kicks out drugs like Tafamidis because it's covalent and it stops subsequent subunit exchange. So it's a really useful reagent. So this allowed us to dose one of Matt Mauer's very famous patients with various increments of the 20 milligram Tafamidis pill. And you can see that oral dosing in this individual decreased the subunit exchange rate by about 70% at the 20 milligram dose. And at the 60 milligram dose, that's probably ultimately going to be used by almost all patients for cardiomyopathy. Basically, you get a complete cessation of tetramer dissociation. And you can also see that in fraction exchange at 96 hours. So there was no animal model for these diseases. And so we used Peter Dick's neuropathy impairment score to characterize these symptoms of peripheral neuropathy, starting with sensory neuropathy and autonomic neuropathy and weight loss, and then proceeding over about a dozen years to cachexia and death if the patients are untreated. So basically, you don't want this neurologic impairment score to go up. So this neurologic impairment score encompasses sensation, muscle strength, and lower limb reflexes, among other attributes. And this trial was designed by Teresa Calejo and Peter Dick and Richard Labadinais from FoldRx, a company that I had the privilege of starting with Sue Lindquist. And basically, you can see that in the placebo-treated patient, the placebo-treated subjects, their neuropathy impairment score keeps going up, whereas in the Tafamidis-treated patients shown in the dark circles, that the ascent is less steep. And this has now been studied for almost 10 years. And I'll get to the later time point data, or sorry, the longer duration data in just a few minutes. The other thing that became abundantly clear in the neuropathy trial is that these patients gained weight, and TTR polyneuropathy patients never gain weight. They almost always lose weight, and as the last slide indicated, ultimately die of muscle wasting, among other problems. Now, before we get to the long-term data, there's a really important take-home on this slide. So there are, of course, two groups in clinical trials. There are those that start on Tafamidis and those that start on placebo, and then after 18 months roll to Tafamidis. I think everybody who's examined this data really carefully agree that the demographics of these groups are about as equally matched as can be. But look at the response rate. So if you start on Tafamidis, your response rate's about 70%. If you delay 18 months, the population response rate goes down below 50%. So this really says, and I really firmly believe this, that ultimately we need to get to treating both polyneuropathy and cardiomyopathy almost as prevention trials. That is, we need to diagnose these people really early, get them on drug, and hopefully they'll do well enough that they'll die of something else. So as you know, liver transplantation was the only approach to treat the familial amyloid polyneuropathy until 2011. And since the liver secretes 95% of transthyretin into the blood, basically you replace the heterotetramers with a wild type homotetramer, which is much slower to dissociate and therefore much slower to aggregate. So this slide, when I first saw it, really brought me to tears. There's a lot of information on this slide from the Portuguese experience, both at Porto and in Lisbon. And you can see that the untreated patients, numbering 675, die over a period of about 20 years. Clearly, liver transplantation extends lifespan. There's no doubt about that. And with time, they've gotten better and better at transplanting earlier and earlier. And the earlier you transplant, the better the patients do. And the Tafamidis data really look very impressive. And now the data is out to about 12 years for the longest treated patient. And actually, the majority of the deaths here are due to transplantation-related complications, which were declared treatment failures, which is why the polyneuropathy trial didn't quite meet statistical significance, at least in the intent to treat population. So in a completely different population, Cecilia Monteiro, a neurologist who bravely came to my lab to do a PhD along with Teresa, in one of the projects, she looked at about 250 individuals who were on commercial tafamidis. And by very careful analysis, demonstrated, I think, without a shadow of a doubt, that 2/3 of the patients respond quite well to 20 milligrams of tafamidis once daily. But 1/3 of the patients who have the VEL30-MET polyneuropathy disease seem like they're not even on tafamidis, even though they are. That's very disturbing. Clearly, there's a comorbidity that must be taking place in these individuals that's driving the disease beyond the proteinopathy, because to the best that we can tell, these individuals who are not responders are stabilized to the same extent as the responders and the partial responders. Of course, I'm sure Rodney talked about the messenger RNA lowering agents. And the only thing that I want to say about these is that it also looks like, with regard to polyneuropathy patients, about 33% of them do not respond to inotericin or patisiran. So we have a lot to learn about that population. Undoubtedly, you've seen pictures like this where, this ventricle separating the left and the right portions of the heart is about 10 or 20 times bigger than it should be. And this heart weighs twice as much due to the amyloid burden. I don't think there's any debate as to whether having an amyloid load in your heart is bad. It is. There's no doubt about that. So this is a cryo-electron microscopy structure that just came out from Marcus Vandrich's group. And it's really quite important, I think, because if you look at a cross-section of the cross-beta sheet amyloid fibril, there's an N-terminal piece and a C-terminal piece of TTR that's there. It certainly suggests that proteolysis occurs after the amyloid fibril is formed. Otherwise, it would be really hard to conceive how this intricate structure could form. So Matt had a lot to do with successfully designing the Pfizer tafamidis cardiomyopathy trial. There were a lot of arguments over the course of years about what the endpoints could be. Turns out, I think that everybody was correct in that both the primary and secondary endpoints were met. I'll go through this quite quickly because I'm sure Rodney showed this, but the results from the Pfizer trial were, I think, sort of predicted by results from Matt's lab, Dr. Rosenblum clearly showed that treating people either with tafamidis or diflunisal, another kinetic stabilizer that John Burke showed was effective for treating polyneuropathy, clearly extends lifespan relative to what is a demographically pretty close match group that wasn't treated, although these are different individuals. So Matt's data really predicted that the Pfizer trial would be positive. This is the pooled tafamidis group, which means that they were either on 20 or 80 milligrams versus placebo. And clearly you can see that tafamidis extends lifespan. Okay, let's see here. Now, a really important take home here is that individuals that were New York Heart Association class 1 failure, 37 of them had a reduction in risk of death of 64% as a consequence of taking tafamidis, compared to less than 40% if the disease progresses. So again, treating these patients really as early as possible is absolutely critical for the best effects. And taking tafamidis decreased the decline in the 6-minute walk test and also decreased the decline in the Kansas City Cardiomyopathy questionnaire. So the last thing I want to talk about, assuming that I have time left, Rebecca, I can't see anything on my screen except the slide. So how much time do I have left, if any?
Take your time. No, you're good.
So one of the really interesting things that came about as a consequence of doing liver transplantation for the past 20 years and extending individuals with polyneuropathy's lifespan is that now we realize that these patients are starting to present with CNS pathology. So this is not the same TTR that's secreted by the liver. That's almost certain. And we know that because in familial patients, they still have the same roughly 1-to-1 ratio of mutant to wild type in the brain, even after liver transplantation, which decreases the peripheral concentration of TTR by more than 95%. So in the brain, the choroid plexus secretes transthyretin. And the concept, again, is that it dissociates, misfolds, and aggregates into a spectrum of structures. And probably the reason that aggregation takes so long in the brain is that the TTR concentration is only 200 nanomolar in the brain relative to about 4 or 5 micromolar in the blood. So about 20-fold lower concentration. Yoshi Sikajima, shown here by PET imaging using agents that were initially developed for Alzheimer's disease, quite beautifully showed that after about 12 to 15 years, these patients whose peripheral symptoms were treated quite effectively by liver transplantation start to have quite a high transthyretin amyloid burden in the brain. And moreover, on the right-hand slide, Louis Maya shows relative to a control group shown in green that these FAP patients have quite a high burden of focal neurologic episodes where people lose consciousness anywhere from, a few seconds to the better part of an hour or longer. And then Teresa went on to make another really insightful discovery in the sense that she started to feel that her patients who were treated a decade ago successfully were showing declines in cognitive function, and using the same examinations that were used in Alzheimer's disease, she showed that nearly 50% of her patients who are older had cognitive decline. So fortunately, tafamidis gets into the brain. The exposure there is not nearly as high as it is in plasma, but relative to the TTR concentration in the brain, these are different individuals where the TTR concentration is shown in brown and the tafamidis concentration is shown in gray. At the 20 milligram dose, we're still substoichiometric. But there's some case reports coming out now suggesting that the focal neurologic episode frequency decreases dramatically in patients after treatment with tafamidis, even at the 20 milligram dose. So we're hopeful that at the 80 milligram dose, this will do a good job in slowing the progression of the central nervous system pathology. So I think it's really clear now that the pharmacologic evidence and the genetic evidence together strongly support the amyloid hypothesis as being the driver of the pathology in the transthyretin amyloid diseases. The idea being that transthyretin aggregation is really driving these pathologies. Unfortunately, we still don't have quantitative data on the rate of amyloid clearance in patients treated with tafamidis or the RNA lowering agents. And that's most unfortunate because we still really don't know whether it's just the inhibition of newly synthesized transthyretin aggregation that's driving the clinical effect, or whether there's some contribution from amyloid clearance, which seems pretty unlikely to me because the amyloid clearance rate is really quite slow relative to the rate of clinical response. Although again, we need to do the right experiments. And both in light chain and AA amyloidosis, the amyloid hypothesis also seems to be the case. So there's no evidence that amyloid fibrils are the main drivers of the pathology in these diseases, but that's not to say that having a heart that's half of its weight as amyloid is a good thing. It is absolutely not. The point just is that individuals might be able to exhibit a clinical response without a substantial amount of amyloid clearance. So I think what's really important in ending, and I think Rodney was getting to this at the end if I understood the question and answer correct, in that, you know, there are some patients that really present with a pure cardiomyopathy, and then others present with a pretty pure polyneuropathy. But there are quite a number of patients that present with eye disease, central nervous system pathology, and you know, these are definitely diseases that affect multiple organ systems to a greater or lesser extent in individual patients. So I think I'll stop there and answer questions. Hopefully I gave you a nice overview of sort of these diseases and our current thinking about what we know and we don't know.
Fantastic. Thank you, Dr. Kelly, so much for that deep dive into transthyretin folding and misfolding, V30M mutation differences between tafamidis response at different doses and polyneuropathy and cardiomyopathy. Really fantastic. And then interesting data about the transthyretin amyloidosis in the brain. Before we move on to Dr. Wall, I just had, and there were some questions in the chat that maybe we can ask at the end, but I wanted to ask you, you know, we see a lot of obviously heterogeneity between who develops ATTR, at least cardiac amyloidosis, but between men and women, with men being much more likely to develop this. What are your thoughts on that? What may be driving that?
It's an exceptionally good question that I'm afraid I don't have the answer to. We've thought a lot about this problem, and we've been stymied with an explanation. I guess our main focus right now is to try to even take one step back and understand why does wild type transthyretin aggregate in 10 to 15% of the elderly. I think we have a crack at understanding that, but understanding the gender selectivity of cardiomyopathy, I really don't know.
An area for future research, right?
Sure.
As they always say. So we'll let Dr. Wall share his screen here. So Dr. Jonathan Wall is a professor at the University of Tennessee School of Medicine, where he directs the Amyloidosis and Cancer Theranostics program, which is focused on the development and translation of biologics for imaging and therapy for systemic amyloid diseases. Dr. Wall is very involved with the amyloid support group, and I've seen him speak a few times, and he has a fantastic new imaging agent that he's working on for detection of systemic amyloidosis in clinical trials, as well as novel therapeutic strategies that may help remove amyloid complexes from the body. So Dr. Wall is going to give us a glimpse into whole body imaging in systemic amyloidosis. And again, we'll share hopefully some fantastic cases in imaging. Dr. Wall, thanks.
Need to unmute, and there you go. Thank you for this opportunity to present some of the data, and I'll talk a little bit about the systemic amyloidosis and whole body imaging, and in particular, some of the studies that we're doing right now as part of a clinical trial. So in terms of a disclosure, I have support, but I will say that during the talk, I'll discuss some preliminary biodistribution data that we've got from this trial using our amyloid-reactive peptide in patients with systemic amyloidosis. Most of this data is part of a interim review of the phase 1 trial. So why do we want to image systemic amyloidosis? So it's a multi-organ disease, and it's often defined as Jeff and Rodney have mentioned, by the major symptomatic organs. So you have cardiomyopathy, you have your polyneuropathy, but the question is, or the picture is much bigger than that, and the full extent of the disease in these patients is really difficult to ascertain. Biopsy is the best way to determine involvement of amyloid in a particular organ, and it's impractical to biopsy every organ. This is particularly true in AL amyloidosis and some of the other sort of rare hereditary ones. The organ distribution and the amyloid load may be of prognostic value. I think we understand that the amount of amyloid in a given organ contributes to the toxicity or the dysfunction of that organ, but what we don't understand is how the amyloid load in the other organs, which might not have reached a toxic load, contributes to overall well-being and prognosis of the patient. The distribution of amyloid we think might be diagnostic. That's certainly true, I think, for AL, LEC2, and TTR, where certain organs are involved. And when you look at pictures of the whole body and amyloid organ involvement, you can make a fairly good guess at which type of amyloid they have. At present, there are no agents, single agents that can image amyloid in all the abdominothoracic organs: heart, lung, kidney, liver, spleen. So that's something that we need to achieve. And we really think there's a clinical benefit to quantifying amyloid load as part of a response to therapy. And one of the caveats to that is you need to be able to quantify the load at diagnosis. And then, as Jeff said, it would be wonderful to be able to look at changes in load in response to therapy and correlate that with quality of life and other metrics of organ function. So we can follow not only the disease, but also amyloid load, and hopefully tie the things together in some meaningful way. And we also think that clinical trials would benefit from being able to demonstrate removal of amyloid, at least in terms of demonstrating mode of action and proof of principle. So the state of art in clinical systemic imaging is in Europe right now. And serum amyloid P component has been used for 20, 25 years to image amyloid. SAP is bound to all forms of systemic amyloid, and it can be isolated from normal donor plasma, radio labeled with iodine-123, which is a SPECT imaging radionuclide. It's injected into patients and they're imaged 24 hours later, either by planar gamma scintigraphy, which is what these images here, or less commonly in SPECT. And these are the types of images they generate. These are patients with AL amyloidosis. You can see on the left there the joint involvement. You can see uptake of the radiotracer in the shoulders. In the center patient, you have spleen involvement and liver involvement. And then the classic sort of AL picture where you have bone marrow involvement and abdominothoracic organ involvement. But because of the nature of this imaging, it's very difficult to see exactly what's involved. And these images are quite difficult to quantify in a specific way, although grossly you can say more or less amyloid is present. Experimentally, as Rodney Falk mentioned, florbetapir is being used in his facility and in London as well to image amyloid systemically. This is some data from the group from London where they show the extracardiac distribution of amyloid as well as the cardiac of the florbetapir. And you can see in panel G here, you can see the uptake in the amyloid in the left ventricular wall and the right ventricle. But also you can see in this patient, there was evidence of lung amyloid in the parenchyma, and you get very intense uptake of the florbetapir imaging here. Various glands and the tongue in the head light up. The thyroid is prominent in these scans. The fat deposits in the subcutaneous area. The liver and hepatobiliary system and the liver and the GI tract all light up. The authors were very cautious as how to interpret this data, particularly with respect to the liver and the GI. It's very difficult to say anything positive about the liver in cases with florbetapir. It's the organ where the radiotracer is actually cleared, so this could be natural clearance through the hepatobiliary system, which would end up in the GI tract, so this could be positive clearance of the radiotracer. And in other data, it's been found that there's difficulty interpreting the renal images as well. There's evidence, I think, that the renal sensitivity with florbetapir is not as high as it could be. But these images are quantitative. It's a tomographic imaging modality spec, so you can generate 3D images and get axial slices. You can get great anatomic resolution, so it's certainly a move in the right direction. What I want to talk about is the amyloid reactive peptides that we've been developing in our lab for the last 5 to 10 years, and how we've exploited them to develop imaging agents for systemic amyloid and actually got to evaluate them in a phase 1 trial. So our rationale when we were looking at something that would bind multiple forms of amyloid was that amyloid deposits contain 2 polyanionic multimers, the fibrils and heparan sulfate proteoglycans. And fibrils and proteoglycans are ubiquitous components of all systemic amyloids. Fibrils themselves are made of different protein components, but there's structural data to suggest that as when they align into fibrils, structurally they look very similar. And glycosaminoglycans are a universal component of all amyloids, contributed by the cells around which the amyloid fibrils deposit. And it was shown quite early on by Ulf Lindahl that the amyloid heparan sulfate proteoglycans are structurally distinct from the heparan sulfate proteoglycans that are found throughout the body in the extracellular matrix and the cell membranes. And what they showed, I think, was it was chemically more similar to heparin, meaning that it had a higher charge density and it was essentially hypersulfated, which meant it could serve as a specific target or biomarker on amyloid that we could exploit using heparin binding peptides. So we went to the literature and we identified a panel of relatively simple, polybasic peptides that bound heparin. They were synthesized and radio-labeled, and we did our initial screen for amyloid reactivity and specificity using a murine model of systemic AA amyloidosis. And we were able to test 7 of these peptides of varying charge, length, charge density, and we identified 1 peptide in particular. And this peptide, when it was radio-labeled, as I say, bound specifically to the AA amyloid in mice. It didn't bind to tissues that were devoid of amyloid. It didn't bind to the liver and spleen, the renal cortex. There were no binding sites there, which are sites of high heparan sulfate proteoglycan density. And then we were able to show using formalin-fixed paraffin-embedded tissues of lots of different amyloid types from patients that this peptide was indeed pan-amyloid reactive, or at least multi-amyloid reactive. This is the peptide that we eventually developed to use in the phase 1 clinical trial. This is a predicted 3-dimensional structure. It's an alpha helical peptide predicted with 12 lysine residues spaced throughout the peptide, such that when it does form an alpha helix, the 12 lysine residues align on one side of the helix, and that's the reason we get the binding, and I'll go into that a little bit more. But in preclinical studies, we radio-labeled this peptide and injected it into the mouse model. And here's 2 images of AA amyloid mouse. This is small animal CT contrast enhanced SPECT CT imaging. Peptide was labeled with iodine 125. these mice get massive hepatosplenic AA amyloid deposits, as well as deposits within the pancreas and throughout all tissues, but at low density relative to those organs. And you can see when we injected the radioactivity, which is shown here in red, we were able to see uptake in the liver, uptake in the spleen, and then there's some uptake in the pancreas as well. In these images, we use IP injected contrast agents so that we can actually define the intestines in the mouse, the spleen, the stomach, and the heart, and the liver. In a mouse without amyloid, what we found was no uptake at all in organs that didn't have amyloid deposits. We saw some radioiodide associated with the stomach. These images are 4 hours post-injection, and some radioiodide associated with the thyroid, which in these experiments was unblocked, and a site for iodide uptake in mammals. The reason that we see the stomach and the thyroid is the peptide that's unbound to amyloid passes through the kidneys. It's taken up by the tubulin-megalin complex in the renal proximal tubules, where it encounters dehalogenases, which strip the radioiodide from the peptide, and that re-enters the circulation to be picked up by halide receptors in the stomach wall and forming HI, which in the lumen of the stomach, which actually goes out through the GI tract and is organified in the thyroid as radioiodide. We were able to demonstrate specific reactivity with amyloid in these tissues that we imaged using micro-order radiography. So in this protocol, the radioactive peptide, when it's exposed to photographic emulsion, develops black silver grains, and you can see perivascular amyloid here in the liver and amyloid within the sinusoids, but it's very specific, it's not uniform. Again, the peripheral regions of the spleen and massive deposits in the kidney. But what's remarkable is when you look at healthy organs that receive the peptide, you see no uptake, no retention at all in the liver, spleen, or kidney in tissues that don't have amyloid. Looking at AL human tissue, using a biotinylated variant of the peptide, we showed very specific uptake in regions that showed Congo red positive birefringence, again indicating specific retention by the amyloid. So these preclinical data were very suggestive and allowed us to go into the phase 1 trial. A little bit about why we think we get specificity to amyloid. In solution, peptide P5+14 exhibits a random coil in phosphate buffered saline. In saline, we can show this by circular dichroism. If you titrate in a ligand, in this case, in the study that we did, we used heparin, but it could be fibrils. What we found was you enhanced the helicity of the peptide, and what we think is the peptide encounters a electronegative surface, highly electronegative surface, begins to form an alpha helix, and eventually if the charge density is high enough on the substrate, you get engagement of all the lysines in the peptide, which gives you high affinity specific binding. If you don't have a high enough charge density on your surface, then you don't get enough lysines engaged and the peptide doesn't bind specifically. And this is sort of demonstrated here in a molecular dynamics simulation that we did at Oak Ridge National Lab. So a little bit about the trial now. We're using iodine-124 peptide in patients with systemic amyloidosis. Iodine-124 is a PET radionuclide. It's readily incorporated into biologicals through a tyrosine, monoiodotyrosine or diiodotyrosine reaction. The half-life is 4.18 days. It's a 25.6% positron emission. So it's quite a low positron yield relative to F18, but equivalent to copper-64 and some of the other reagents. And it's a cyclotron-produced radionuclide. So the design of the trial, the first 3 patients were required to be AL patients with at least 2 organs and 2 organ systems involved, not including the nerves. And they were given I-124 P5+14 for initial evaluation of safety and dosimetry. And to achieve that, the patients were imaged 7 times over 48 hours. We've completed that. In phase 2 of the trial, we're recruiting at present 40 patients. The FDA required us to separate the grouping of the patients in association with the perceived at the time relative amount of disease prevalence in the population. So we're doing 20 AL, 10 AL kappa, 10 AL lambda, 10 TTR, 5 LEC2, and 5 other. So hereditary sort of rare forms. And these are the patients we've imaged to date. All 5 TTR patients we've imaged have been hereditary, mostly T60A, the Appalachian mutation. And we've imaged 3 patients with other forms of amyloid, a localized AL, A-lysozyme, and A-gelsolin. Again, these patients were included for us so that we can demonstrate this multi-reactivity actually in patient populations as well. Each patient receives about 1.3 milligrams of peptide and 2 millicuries of radioactivity. And we image the patients at 5 hours and 24 hours post-injection. When we initially designed the trial, we had no idea of the clearance rate of the peptide in patients. And so we included a later time point to ensure that we got good signal-to-noise data in at least one of these 2 time points where background would have cleared out and retention of the peptide would have been optimized. In future studies, we're going to probably leave out this 24-hour post-injection study. The phase 1 is designed to assess safety and determine whether we can image individual organs that are known or suspected to contain amyloid based on the clinical record. So since every patient we recruit has a known diagnosis of amyloidosis, one of the goals of the trial is to assess the organ-specific sensitivity. This is the blood time activity curve washout from the first 3 patients. The first patient received 0.3 millicuries of iodine-124. Patients 2 and 3 received 1 millicurie. The kinetics of whole blood washout were quite similar for all 3 patients, regardless of the amyloid load, with half-lives, distribution half-lives of 14, 15, and 23 minutes. And elimination half-lives varied quite a lot, but that might be apparent when you look at the scans. So these are the time course washouts for those 3 patients. In patient 1, we had very rapid 25 minutes. You can see the spleen, the kidneys, the liver was quite weak, and then the parotid salivary glands and thyroid gland lit up quite well. But as you wash out the 48 hours post-injection, the spleen activity was retained, the kidney activity was retained, as was the activity in the head and neck. In contrast, the other 2 patients looked drastically different. In patient 1, there was high uptake in the liver, or visualization of the liver, which washed out very rapidly until about 6 hours. It's not visible, but you can see cardiac uptake in this patient, as well as some pleural lung uptake in this patient, which persisted almost, well, to 48 hours post-injection. And in the 3rd patient, you can see everything washes out, even in the thyroid and the glands, except this patient had cardiac amyloid. So each patient, the washout rate for each organ was very different. And since we don't have healthy subjects enrolled in this study, we use the next patient to try and understand a little bit more about the specificity of how this peptide binds to amyloid. And we were quite gratified to see that within the first 3 patients, we had very different imaging at the time points that we were going to use. So the 6 hours, this patient had spleen and kidney uptake, as well as maybe some GI, which persisted at 24 hours. This patient was heart, a little bit of renal uptake, no spleen, no liver, and some lung. And this patient was almost exclusively heart and some lung uptake, but no spleen. This is the stomach, no spleen, no liver, and no kidneys. So we were quite gratified and hopeful that this peptide was binding amyloid specifically in individuals. So this is the classic pattern of uptake that we see in AL patients, that we see a lot in the scintigraphic imaging with SAP. These are maximum intensity projections from the PET CT. So this is all the photons sort of stacked on top of one another. This is not a tomographic image, but you can see uptake in this AL patient in the joints. This is the liver, the spleen uptake, both kidneys. This is the urinary bladder, and you can see bone marrow involvement as well. There's indication in this 1D image that there may be some cardiac uptake. This is the same patient, again, just showing all the wide distribution and heterogeneous distribution, but it's characteristic of AL. When you look at the transaxial slices and coronal slices of that patient, you get a better indication. This patient was quite remarkable in that he was diagnosed with hepatic amyloidosis based on a biopsy of the liver. That was his primary organ. But when we looked at the images, we could see clearly there was uptake of the radiotracer in the left ventricular wall and perhaps the atrium in this patient. This is the liver. This is the GI tract. When you look at the transaxial slices, you can see the spleens involved as well. This is actually the pancreas. We've noticed in several of our patients, those with type 2 diabetes, which have been 2 or 3 of the cohort, as well as patients that have multi-system high amyloid load, that we actually see pancreatic involvement. Of course, the pancreas is associated with the deposition of islet amyloid polypeptide in type 2 diabetics. It's almost uniform and extensive when patients become insulin dependent. This radiotracer can't discern between IAPP and the amyloid that the patient has systemically, but that's an interesting phenomenon, and we're going to try and learn a little bit more about that. And it may be a combination of both IAPP and the amyloid, AL in this case, depending on amyloid load. This is the liver. This is involvement in the liver. Again, in this patient, you can see quite exquisite uptake in the left ventricular wall, right ventricular wall, and the right atrium. And in this patient, even though it's weak, there is renal uptake of the radiotracer. This is another patient. This is a young woman who was diagnosed with renal AL amyloidosis to the extent where she was had a kidney transplant before her stem cell transplant, massive abdominothoracic amyloid, involvement of the bone marrow. But what was remarkable about this patient is that we were actually able to image the choroid plexus and the pituitary. When you look at the axial slices of this patient, you can see in greater detail there is some heart involvement, but it's weak relative to the liver and the spleen. Because of the renal dysfunction or renal failure that she suffered early on in the diagnosis, she developed a lot of calcium in the liver and spleen. So where you can see the calcium deposits, this is in the liver, there's no uptake of the radiotracer, but where there's tissue, there's amyloid and there's radiotracer uptake. This patient, again, consistent, we think perhaps with a large amyloid load in abdominothoracic organs, had showed pancreatic uptake of the radiotracer. This is the bone marrow, and in the transaxial slices, you can see quite vividly uptake in the choroid plexus and in the pituitary. And AL amyloid has been described previously by Sasaki in the choroid plexus in a series of autopsy-based studies in 6 out of 7 in the cohort that they actually studied. What was remarkable about this patient was that she had all 3 kidneys. So this is the right kidney, failed and positive for amyloid. This is the left kidney, failed and positive for amyloid. But this is the transplanted kidney in the pelvis, and there's absolutely no retention at all of the radiotracer. And consistent with that, she had EGFR of about 98. So absolutely excellent renal function and evidence that the transplant has no amyloid involvement, despite the fact that her amyloid load was perhaps the greatest we've seen in any patient. Some other manifestations that we see in our patients with AL, this is patient 3 that I was just talking about. This is pleural amyloid. This patient was diagnosed based on lung amyloid for a pleural biopsy, and we were able to see that quite vividly in this patient. And this is a patient that was diagnosed with cardiac amyloid, and what was remarkable about this is the involvement of the right ventricle, and you can see the atria as well. Left ventricular wall is involved, massive enlargement of the heart. This patient also had evidence of kidney uptake as well. And when you look at that patient through different slices, you can see both kidneys were involved. And this patient, we were actually able to see some evidence of maybe tongue involvement. Accumulation of radioactivity in the mouth, which could be interpreted as amyloid involvement in the tongue, which is not common in patients with AL, but has been seen in a subset. It's quite difficult to make that call definitively because the salivary glands build up of free radioiodide and it leaches into the mouth. And so you do see radioactivity in a lot of the patients sort of in the oral area, but this was so well defined and at the back of the tongue that the radiologist actually called it positive for tongue involvement. This is another patient that I just wanted to point out the pancreas. This is the first patient that received the 0.3 millicurie dose of activity. This patient is a type 2 diabetic, insulin dependent, and we were able to see even though the only organ that has real extensive amounts of amyloid is the spleen, the kidneys are involved, but weakly. There was no uptake in the liver. So this isn't a massive amyloid burden systemically. but you do see activity in the pancreas, which in this case may be representative of IAPP accumulation associated with type 2 diabetes. So what does normal look like? It's well known in patients with AL amyloidosis who respond exceptionally well to stem cell transplants and chemotherapy that the amyloid can disappear, and this has been shown by SAP imaging in Europe. And this is a patient that was diagnosed in 2013 with renal amyloidosis and a very poor eGFR, about 28. And after a stem cell transplant and a single dose of chemotherapy, the patient went into complete hematologic remission, meaning the light chain was completely turned off and was stable in that state. And then when we imaged them, we saw absolutely no uptake in any organs except the stomach, this is the free iodide in the stomach, and it's extremely intense and extremely bright because all the peptide that was injected was catabolized, and all the free radioiodide we anticipate or we suggest ended up in the stomach because there was no retention anywhere else. This is the heart in transaxial view, and you can't see the characteristic horseshoe, you just see some blood pool. The liver is clean, the kidneys are clean, and the spleen is clean. So this is what normal looks like if you have no amyloid whatsoever, just a hot stomach and then some activity in the glands in the neck and head. So looking at TTR patients, these are 3 TTR patients that were diagnosed with cardiomyopathy. These are the NT-proBNP values for these patients, and quite characteristically, we see uptake in the left ventricular wall of all 3 patients. In this patient, you can actually see the right ventricle as well. This is the urinary bladder, so quite a lot of the radioactivity has passed through the kidneys as well. This is the stomach in this patient, this is the stomach, and this is the stomach. But everything else is clean. The liver is clean, kidneys are clean, and the spleen is clean. And so what was remarkable about this is 2 of the patients had very high NT-proBNPs, characteristic of cardiomyopathy. The central patient had an NT-proBNP of 52, but he was sent to us because of genetic predisposition, and he had a heart to contralateral ratio in a PYP scan of 1.26, which is equivocal. These 2 patients were diagnosed with polyneuropathy, TTR, and both these patients had normal to high normal ranges of NT-proBNP. Both had neuropathy and no evidence of cardiomyopathy, yet in both patients we were able to detect left ventricular wall uptake with the PET CT scan. This is the stomach, this is normal, this is the stomach, and this is normal. So this is amyloid that is not detectable by any biomarker means, and hasn't not been detected in any functional tests either. So it's quiet, silent. One of the polyneuropathy patients came with crippling neuropathy in the legs and with muscle atrophy, and this is the scan from his legs, and we were able to see in the CTs these areas of CT-like regions, very little musculature, and then when we overlay the PET data, it co-localized quite well with these regions, and even though this is early data, the radiologist is interpreting this as possible uptake in neuropathy within the legs of this patient. I won't go into that. So to speak a little bit about the rare diseases, this is 2 patients with ALEC2 amyloidosis. So ALEC2 is characterized by deposition in the kidneys, which is the organ where the biopsy is generally taken to prove the type of amyloid. The spleen is invariably involved. The adrenal glands are invariably involved. The heart, even though there is amyloid in the heart, it's scant and perivascular. So in this patient, we see kidney involvement. This is adrenal, and this is the spleen. In the second patient, we saw accumulation of the radiotracer in the liver again, which is characteristic in LEC2. But the adrenals from this patient were absolutely remarkable. They were indeed the organ that had the highest accumulation of amyloid based on intensity. This is a patient with Gelselin. Primary manifestation was in the nerves, or physical manifestation was in the nerves, in the face. But when we imaged the patient, we were able to detect massive accumulation of the radiotracer in the liver. And also we were able to detect some gross deposits or gross uptake of the radiotracer in the legs. And this patient did admit to us that she had peripheral neuropathy or problem walking, as well as the facial neuropathy, and but no evidence of renal involvement. And the last hereditary patient we've done is a patient with lysozyme amyloid. This patient was quite remarkable in that he'd been to London to get an SAP scan, so he knew exactly where his amyloid was, but he didn't share it with us. And when we did the imaging, we were able to show uptake in the liver, uptake in both kidneys. This is some GI uptake, spleen, but also in the heart. So SAP cannot image amyloid in the heart. And so that was the question. That's why he came to us, is to address that. And when you look at this slice here, you can see actually activity in the heart. But it's very discrete and different from what we see in AL and TTR patients. This is more associated with the luminal side of the heart and less with the ventricular wall. But again, you can see organs associated with amyloid that he knew about. This is the pancreas. He also had pancreatic uptake and was a type 2 diabetic taking insulin. So one of the important things of being able to do all this is to monitor response to therapy and be able to say something about how amyloid's changing. And to do that, you need to be quantitative. So we've developed a method to determine the standard uptake value ratio, where we draw regions of interest around the organ that we're interested in, and we draw a region of interest around the blood pool in the aortic arch, and that serves as a reference tissue. And we're able to come up with a value for amyloid load in the organ. And we've developed a rather simple way of developing a threshold where we've picked a value where the radiologist says below that, it's visually negative. And so this is everything above this threshold was visually positive and also mathematically positive, and everything below was mathematically negative based on the SUVR. In the kidney, we got great concordance as well, except for this one patient where numerically it would have been positive, but visually it was negative. In the spleen, there was excellent concordance. In the liver, there was less concordance, but I think our radiologist was being cautious in interpreting the liver. So with that, what have we learned? The infusion of the peptide is well tolerated by all patients. Imaging at 5 hours post-injection provides excellent data with low blood pool background. The peptide can image multiple organs, heart, lung, liver, spleen, kidneys, adrenals, the pancreas, and it has the sensitivity and could probably have better sensitivity with state-of-the-art imaging equipment to generate images of the nerves. We're able to see the small deposits within the pituitary and the choroid plexus in 2 patients now, not just one. The patient one has image sensitivity. We're at 90% for the 24 patient cohort to date. We've imaged at least 5 different types of amyloid, and we're hoping to recruit many more variants, rare hereditary forms, to see if the peptide will work in those as well. And the data suggests that we can image amyloid in the heart and other organs before serum biomarkers become evident of cardiac dysfunction and renal dysfunction. So the idea that we can now image subclinical amounts of amyloid speaks to what Jeff was talking about, in that these therapeutics that inhibit or slow amyloid deposition are best used in patients that are asymptomatic but have amyloid. And at that point, they may never become symptomatic. And that's, I think, one of the holy grails for amyloid therapy, is that we can prevent them from becoming symptomatic and they can live with their amyloid load. And with that, I'd like to thank the team and everybody else, and Brett for inviting me to talk. And I really appreciate it. Thank you very much.
Absolutely. Thank you so much for that. You know, your imaging agent makes me think about a comment that a mentor of mine once made to be about systemic sarcoidosis, which is that sarcoidosis is like looking into the makeup mirror. And if you look close enough, you're going to find some abnormalities. And so I think if we continue to get more specific and more sensitive imaging agents in amyloidosis, we may find the same problem here. So we're almost done with time, but I wanted Dr. Falk to had a question for Dr. Kelly about Tafamidis and the different dosing.
Actually, can you hear me okay? I think that Jeff has gone. But if you are there, or I want to throw it to the audience, the recommended dose from the FDA is 80 milligrams. There's two ways of getting Tafamidis in the United States. One is a 61 milligram Vindex, and the other is 80 milligrams Vindex, which is a 20 milligram tablet. The VA, and if you know this, but the VA is only allowing patients to get 20 milligrams because they looked at the data and feel 20 milligrams and 80 milligrams in the published trial don't show a lot of difference. So the question I had for Jeff is, what about 40 or 60? And there are about a third of patients in the United States who have a very significant copay, even with Medicare, which may be well over $1,000 a month. And I'm actually advising some of these patients to at least halve their costs by just getting a prescription for 80, but only using 40. I don't know if you have any thoughts on that, Brett, or anybody else in the audience, or Jeff, certainly, if he's still listening.
I think Jeff's on.
I am.
You are, sorry.
Hi, Rodney. Well, you know, I'm not as familiar with the 80 milligram and 60 milligram formulations and how the pharmacology works if you were to split the tablets. So I certainly can't make any scholarly comments about that because I just don't know. You know, the study that I showed had to do with the 20 milligram tablets, which were rather large. And the patient either took 2 of them or 3 of them to get to 40 and 60.
No, the 80 milligram dose, Jeff, is 420s. 61 right. Is a single 61. So,
right. So I believe, you know, Matt can certainly jump in here, but the reason that the regulatory agency approved the higher dose was apparently based on the biomarker data, which to the best of my knowledge hasn't been published yet. So that would be my only reservation about, you know, kind of reducing the dose. I mean, biochemically, it's at least in the couple of patients that we've looked at very carefully, 60 milligrams gives complete biochemical stabilization. So I think if I were a patient, I would want to be there.
You think there's a lot of patient-to-patient variability? In the phase 2 study, where we had about 13 patients or so, way back on Tafamidis before it even had a name, we have 2 of them still alive 8 or 9 years later, absolutely rock stable, and the rest progressed. So could you comment on that?
Well, you know, I think we absolutely have to figure this out, because we see the same thing in polyneuropathy, that, you know, Teresa has a lot of patients who are stable 10 years out, and some that progress like they're not even taking Tafamidis. So there's something else going on. And the fact that you also see this with the RNA lowering agents, I think that it's not, I think all of these agents treat the proteinopathy component. I mean, the conclusion I draw is that there's something else, perhaps inflammation, perhaps the immune system, or something that's driving pathology in a subset of the patients. And no matter how much you correct the proteinopathy, you're not going to help those patients.
Thank you.
Well, thanks everyone for coming on, and to be respectful of everyone's time, we'll end it here. But we'll have another session tomorrow, same time, same login for everyone. Password and everything is the same, and it'll be a session more specifically on AL amyloidosis with a clinical focus. And so thank you all for logging on, and we'll see you tomorrow.